So if you are looking at your syllabus right now, trying to synthesize this massive scope of global public health.
Right. It is definitely a lot.
Yeah, and you are trying to balance that with clinical rotations or ward rounds or your public health modules. You already know the challenge.
Absolutely.
You are basically trying to master the foundational frameworks of global health without getting just entirely buried under an avalanche of dates and geopolitical acronyms.
And the epidemiological statistics, I mean, it is a mountain of data.
It really is. And that is a crucial mission, but it is also an incredibly heavy lift when you are just staring at textbook pages. So we are here to validate that effort.
Yes, we see you doing the work.
Exactly. And more importantly, to help you build a mental scaffolding so that these concepts actually stick.
That is the core objective here. Knowledge is really most valuable when it is understood and applied. We do not want to just recite a timeline of global health milestones for you.
Right. Nobody needs an audio textbook.
No, exactly. We want to take the raw, dense material you are studying and transform it into a functional conceptual framework. The goal is to give you the specific lenses through which you can view the world of global health.
So when you are standing in front of a patient or tasked with evaluating a new health policy, you actually understand the forces at play.
Right, the historical, economic, and systemic forces that created the exact situation you are looking at.
Okay, let's unpack this. This deep dive serves as your dedicated conceptual companion to Chapter 1.3 of the Oxford Textbook of Global Public Health.
The chapter on the history and development of public health in low- and middle-income countries.
Yeah, that is the one. And just a reminder, we are not going to read the chapter to you line by line. You really need to actively read it yourself.
This is a companion, not a replacement.
Exactly. What we are doing is clarifying its frameworks and strengthening your clinical and systemic reasoning to support that reading. We are going to look at the geopolitical, economic, and historical blueprints that quite literally built the world's current health systems.
And to do that effectively, we first really need to define our scope.
Yeah, let's get the definitions down.
When the literature discusses low- and middle-income countries, or LMICs, what exactly does that mean in a measurable sense?
Because it is a term we throw around constantly.
Right. So according to the United Nations classification used in our source text, which relies on per capita gross national income, or GNI, from the 2011 baseline, we are looking at a very specific set of economic brackets.
Break those down for us.
Sure. Low-income countries are defined as those with a per capita GNI of $1,005 or less.
Just over $1,000 a year per person.
Yes. Then lower middle-income countries fall between $1,006 and $3,985. And upper middle-income countries range from $3,986 to $12,275.
And to put a human scale on those economic brackets, we are talking about roughly 112 countries.
It is a massive block of the globe.
It is. Even if we explicitly exclude the really massive outlier populations like Brazil, China, and India from this specific UN grouping just for a moment, the population of these remaining LMICs still hovers around 3 billion people.
Nearly half the global population.
Right. So when we analyze public health development in these nations, we are quite literally analyzing the health trajectory of the world. It is not some niche topic.
No, it is the dominant narrative of global health entirely.
So what is fascinating here is that to truly understand the current, often fractured state of public health across those 112 nations, we have to introduce an overarching framework.
We need a conceptual metaphor that we can carry with us through this entire deep dive to anchor all these historical facts.
I love a good framework. What are we calling this one?
We can call this framework the unfinished architecture of equity.
The unfinished architecture of equity. That is a powerful visual.
It really is. Because if public health in LMICs is a sprawling, ongoing architectural project, we have to look critically at who actually laid the initial foundation.
And why they laid it.
Exactly. The reality is, the initial foundations of these health systems were laid during the colonial era.
Right.
But the critical distinction for your systemic reasoning is this. Those early foundations were never built to shelter the indigenous populations.
They were built like fortresses.
Precisely. Fortresses. They were specifically designed to protect port cities, military garrisons, and the economic productivity of the colonial powers.
So the blueprint was fundamentally extractive, not universal.
Extractive is the perfect word. If you look at European public health during the 18th and 19th centuries, it evolved largely alongside domestic urban reform.
Driven by the Industrial Revolution.
Right, the need to manage squalor in cities like London.
Right.
But in the colonies, disease control had a completely different mandate. It was almost exclusively about protecting trade routes and colonial administrators.
Because a sick workforce or a quarantined port hurts the bottom line.
Exactly. International health diplomacy really only began to take shape in the mid-1800s, and it was entirely focused on protective legislative measures.
Like quarantine laws.
Yes, these early international conventions were designed to stop diseases like cholera and plague from disrupting maritime commerce.
They weren't sitting around thinking about how to improve the health of the colonized population.
Not at all. It wasn't until the aftermath of the Second World War in 1946 that the World Health Organization was born, finally stepping in as the first truly international agency with a mandate to direct and coordinate global health work.
Okay, so if we follow this architectural timeline to the mid-20th century, the era of decolonization hits.
A massive geopolitical shift.
Yeah, you suddenly have dozens of newly independent nations inheriting these colonial fortresses. And overnight, the mandate changes completely.
The national governments have to frantically remodel and expand this exclusionary fortress to fit their entire newly liberated population,
But they're attempting this massive renovation while dealing with a leaky roof.
which represents the overwhelming endemic burdens of infectious diseases.
Right, and a profoundly cracked foundation, meaning they have extremely poor physical infrastructure, crippling workforce shortages, and almost zero fiscal capacity to actually fund the expansion.
If we connect this to the bigger picture, it explains precisely why you cannot comprehend today's global health disparities without analyzing this historical and economic blueprint.
You can't just look at the epidemiology in a vacuum.
No, decolonization created an ambitious, necessary opportunity to reimagine national health systems, but the structural deficits were staggering.
You simply cannot build a modern, equitable, universal health system overnight on a foundation that was originally designed for resource extraction.
And the selective protection of a ruling minority. The architecture was fundamentally misaligned with the new goals of these independent nation-states.
Which brings us perfectly to the ultimate bedrock of this entire architecture: environmental health.
This is where the blueprint and the foundation actually meet the dirt.
We are talking about the absolute basics: public housing, public water supply, personal hygiene, and sanitation infrastructure.
The unglamorous stuff.
Very unglamorous, but completely vital. The text gives us a truly striking contrast that highlights the uneven nature of this building project.
The water versus sanitation data.
Yeah. By 2010, the population utilizing improved drinking water sources and LMICs had increased from 70% in 1990 to 87%.
On paper, that sounds like a massive, undeniable victory.
It really does. 87% have improved water access. But then you look at the sister statistic: sanitation.
This is where it falls apart.
In 2010, the population using improved sanitation in those exact same countries was still sitting at less than 50%.
This raises an important question, and it is one you will encounter frequently in health policy analysis. Why does this massive discrepancy exist?
Why does water get funded and built so quickly while sanitation is just left so far behind?
To the point that an estimated 2.4 billion people globally still lacked access by 2010.
2.4 billion.
It ultimately comes down to political priority, the complexity of financing, and the immense difficulty of shifting human behavior.
Let's break that down. Water first.
Providing an improved water source like sinking a protected tube well or piping a spring is largely a mechanical, straightforward engineering challenge.
It's highly visible.
Extremely visible. It is structurally localized, and frankly, it is the kind of project that politicians absolutely love to cut ribbons for.
Right. Everyone loves a new well in the village.
Exactly. Sanitation, however, is vastly more complex.
Because when we talk about improved sanitation, we aren't just talking about digging a simple hole in the ground.
No, we are talking about flush systems connected to a deep sewer network or properly ventilated, improved pit latrines.
That requires enormous, largely invisible underground infrastructure.
Precisely. It historically receives a much lower priority from governments because the political return on investment is less obvious. You can't take a great photo standing next to underground sewage pipes.
Fair point.
It suffers from inadequate financing due to the sheer scale of the civil engineering required. And most critically, from a public health perspective, sanitation requires difficult, sustained behavioral and hygienic shifts from the entire population.
You can build the latrine, but if they don't use it or don't wash their hands,
Then the public health benefit is entirely neutralized. The cultural practices have to shift in tandem with the infrastructure.
for you listening, this is exactly where we need to lock in a crucial conceptual framework for your clinical reasoning. the fundamental difference between a hazard and a risk.
This is huge.
We use these terms interchangeably in casual conversation, but in public health, confounding them leads to terrible policy. So how do we differentiate these when we are looking at this massive gap between water and sanitation?
It is a vital distinction. The hazard is the intrinsic biological danger.
The bad thing itself.
Exactly. In this context, the hazard is the presence of pathogenic organisms like Vibrio cholerae or Salmonella typhus in the human environment.
Okay, so what is the risk?
The risk is the actual statistical likelihood that a person will be exposed to and subsequently harmed by that hazard.
I see. So the pathogen is the hazard, but the lack of a toilet creates the risk.
Exactly. When a population lacks improved sanitation, you are drastically increasing the risk of exposure to the hazard. The pathogens are introduced directly into the living environment, the groundwater, and the agricultural soil.
So prevention in environmental health is what we can call upstream engineering.
I love that term, upstream engineering.
The mandate is to fix the plumbing, manage the waste, and separate the human habitat from the hazard long before the clinician is forced to treat the resulting cholera in a hospital bed.
It is the only sustainable way to build a foundation.
And the text highlights a glaring vulnerability in how this foundation is currently holding up. You might celebrate that 87% water coverage, but there is a shocking systemic lack of adequate sanitation in major public hubs.
Yes, the places where people actually gather.
We're talking about wet markets, movie theaters, schools, large office buildings, and terrifyingly, even hospitals and peripheral health centers.
That is the most concerning part.
If the foundation of sanitation is weak in the exact places where the population congregates the most, the entire house is incredibly vulnerable to collapse at the first sign of an outbreak.
And when that environmental foundation is weak, the house remains perpetually vulnerable to what the literature calls the old scourges.
The old scourges. These are the massive cripplers and killers of the 18th and 19th centuries.
Pathogens that, by all rights of modern medical science, should be absolute relics of the past.
But because of this unfinished architecture, this lack of basic upstream engineering, they continue to threaten millions of lives.
That reality pulls us directly into the history of these old scourges and the vital concept of surveillance.
If we are looking at scourges, we absolutely have to start with smallpox.
The undisputed gold standard of global health.
It is the ultimate 20th century public health success story, eradicated from the face of the earth in 1980.
But before that victory, we are talking about a viral disease that infected thousands upon thousands.
With a case fatality rate that often hovered between 30 and 50%.
It was devastating. Those who were lucky enough to survive were frequently left with severe, disfiguring pox marks.
And it was a leading cause of blindness globally.
And yet today, there are 0 naturally acquired cases anywhere on the planet.
We just maintain an emergency stockpile of over 60 million doses of vaccine in highly secure locations, just in case.
What is essential for you to grasp here is not just that smallpox was eradicated, but the specific mechanisms of why the eradication succeeded.
Right, the how is just as important as the what.
Especially when it had to be executed in LMICs that possess incredibly weak baseline health infrastructures.
Because early in the 19th century, smallpox control was severely hindered by impure, unstable vaccines.
And poor inoculation techniques and a general lack of coordinated commitment from those colonial administrations we discussed earlier.
So what was the turning point?
It occurred in 1958 and was radically intensified by the WHO in 1967. This success relied on very specific technological and strategic leaps.
First, the technology.
Yes. The technological breakthrough was the widespread availability of adequate supplies of highly effective, freeze-dried, heat-stable vaccines.
Freeze-dried and heat-stable, we really need to pause on the significance of that.
It changed everything.
If you are a junior doctor right now, and you have ever tried to organize a vaccination drive in a rural district near the equator, dealing with rolling power blackouts, broken refrigerators, and impassable roads, you know intimately that the cold chain is the ultimate bottleneck in global health logistics.
It is the bane of field work.
If a vaccine must be kept between 2 and 8 degrees Celsius from the factory in Europe all the way to a village in sub-Saharan Africa, you're going to lose massive amounts of stock to heat spoilage.
A heat-stable vaccine completely changes the logistical game. It allows the architecture of prevention to reach the most remote areas on Earth.
And crucially, these were provided essentially free of cost by major global producers.
Yes, notably through unprecedented cooperation between the United States and the Soviet Union during the height of the Cold War.
Which is wild to think about.
Public health transcending geopolitics? But technology alone didn't eradicate the virus. The strategy had to match the science.
Right, having the vial doesn't put the needle in the arm.
Absolutely. The strategic implementation was equally vital to the biological tool. The WHO deployed a highly adaptive dual strategy.
They certainly utilized routine and mopping up mass vaccination campaigns to build general herd immunity.
But they coupled that broad approach with a laser-focused strategy. Intensive case detection, aggressive contact tracing, strict isolation of active cases.
And ring vaccination.
Yes, ring vaccination, which meant targeted, immediate vaccination of all susceptible individuals in the direct vicinity who might have been exposed to the index case.
It was a highly active, aggressively targeted epidemiological intervention.
They actively hunted the virus down to its final transmission chains.
Okay, so we proved that targeted eradication works. We beat smallpox.
We did.
But then as a clinician, you look at a disease like yellow fever, and the timeline seems completely paradoxical.
The yellow fever story is frustrating.
The text explicitly notes that we have had a highly effective vaccine for yellow fever since 1940.
1940, decades before the intensified smallpox campaign.
Yet, yellow fever remains deeply endemic in 34 African countries, and it continues to cause an estimated 180,000 cases in sporadic, terrifying outbreaks almost every single year.
It just refuses to go away.
How on earth did we eradicate smallpox globally, yet we are still fighting yellow fever almost a century after inventing the vaccine?
This paradox is exactly where we must draw a sharp line between two critical epidemiological concepts: vaccine efficacy and vaccine effectiveness.
Efficacy versus effectiveness.
Exactly. Efficacy is a measure of how well the vaccine works in a perfectly controlled, ideal clinical trial setting.
Like in a lab with perfect subjects.
Right. By that metric, the yellow fever vaccine is a marvel. It is highly efficacious, providing near lifelong immunity with a single dose.
So what's the problem?
The problem is effectiveness, which, in this broader public health context, is heavily dependent on population coverage. It is a measure of how well you actually deliver that vaccine to the vulnerable populations at risk in the messy real world.
Because of deeply inadequate health infrastructure.
The cracked foundation of the unfinished architecture.
And consequently, inadequate routine immunization coverage.
Right, so the wild yellow fever virus easily finds susceptible hosts. Furthermore, we must consider the biological complexity.
Yellow fever isn't just a human-to-human virus.
No, it is an arbovirus. It involves vector mosquitoes and non-human primate reservoirs in the jungle cycle.
It has an environmental and zoonotic complexity that smallpox simply did not possess.
Smallpox was exclusively a human pathogen, no animal reservoir. You cannot eradicate a virus if it can hide indefinitely in jungle canopy monkeys.
You can't vaccinate all the monkeys.
Exactly.
Here's where it gets really interesting, especially regarding how a health system is supposed to track these complex scourges before they explode into epidemics. Let's introduce the concept of systems thinking, specifically viewing surveillance as an early warning radar.
The radar metaphor is perfect here.
Let's look at plague. Yes, the actual bubonic and pneumonic plague.
The Black Death.
You might instinctually think of it as an ancient medieval disease, but the text starkly points out that it has resurfaced significantly in the 21st century across 16 countries in Africa, Asia, and the Americas.
Resulting in roughly 12,500 human cases over a recent 10-year period.
And terrifyingly, 3/4 of those affected died.
It is still exceptionally lethal.
So how does a modern or even a developing health system utilize surveillance as a radar to stop a pathogen like Yersinia pestis?
True public health surveillance is not passive data collection. It is about gathering actionable intelligence long before the crisis peaks in the emergency department.
It's proactive.
Yes. For the plague, a robust, functioning public health infrastructure doesn't just wait for humans to show up at the local clinic coughing up blood or presenting with swollen necrotic buboes.
By then, it's way too late. That is a late-stage failure.
Exactly. Instead, they monitor the environment. They monitor what are known in the field as rat falls.
The rat falls.
Yes. This involves actively tracking and investigating the unusual sudden deaths of rodent populations around human habitats.
Because the rats die before the humans do.
Right. Recognizing that specific environmental trigger, The die-off of the animal reservoir, which forces the infected fleas to abandon the dead rats and seek human hosts, allows the health system to act
To initiate early active case finding.
and stockpile appropriate antibiotics like streptomycin or doxycycline, and deploy aggressive vector control to kill the fleas before the human outbreak spirals out of control.
That is what a functioning early warning radar looks like. It detects the hazard before it becomes a widespread human risk.
And we have seen exactly what happens when that radar completely fails or when the physical foundation of the health system is violently compromised.
The results are always catastrophic. Take cholera.
A prime example of infrastructure collapse.
The text highlights the devastating 2010 earthquake in Haiti. In the aftermath of that massive seismic destruction, the cholera outbreak resulted in over 230,000 people affected and more than 4,500 deaths.
When the physical infrastructure, the water pipes, the sanitation systems, the hospitals collapses, the old scourges rush right back into the void.
And because the widely effective oral vaccines against cholera were still largely under development and not broadly stockpiled at the time of the quake, the only defense left was frantic upstream environmental health.
It meant flying in clean water, establishing emergency latrines to separate feces from the drinking supply,
And rushing improperly formulated oral rehydration therapy to save people from dying of profound dehydration and hypovolemic shock.
It is a tragic but perfect illustration of our core framework. An architectural blueprint for national health simply cannot rely exclusively on treating the sick.
It must fiercely, proactively protect the environment that keeps the population well in the first place.
When the environment breaks, the clinical system is instantly overwhelmed.
Which transitions us beautifully into the massive systemic efforts to build immunity when the environment can't be perfected. We have to talk about the EPI revolution.
And the strategic tension of the vertical approach.
EPI stands for the Expanded Program of Immunization, which was launched by the WHO in the mid-1970s.
The overarching, highly ambitious goal was universal child immunization, or UCI.
Practically, this meant fully immunizing at least 80% of all children globally by their second birthday with a core set of essential vaccines.
Right, the basics. DTP for diphtheria, tetanus, and pertussis. BCG for tuberculosis, measles, and polio.
Before we delve into the logistics of UPI, let's establish another vital conceptual framework for our listeners. In public health policy, we must clearly differentiate between control, elimination, and eradication.
These terms are often used carelessly in the media, but epidemiologically they represent entirely different operational end states.
So what is control?
The EPI started out largely as a control program. Disease control aims to reduce the incidence, prevalence, morbidity, or mortality of an infectious disease to a locally acceptable level.
You are managing the fire, not putting it out completely.
Exactly. But over time, as technology and logistics improved, the ambition for certain specific pathogens shifted.
Towards elimination.
Yes, elimination means reducing the incidence of an infection to zero within a specific, defined geographical area.
Like how the Pan American Health Organization successfully eliminated endemic measles transmission in the Americas by 2002.
Right, but continuous intervention is still required to prevent reestablishment from imported cases.
Because the fire is still burning in other parts of the world.
Exactly. Finally, eradication is the permanent, absolute reduction to zero of the worldwide incidence of an infection. Routine intervention is no longer needed.
And as we discussed, smallpox is the only human disease we have achieved this for.
But we are agonizingly close on another one. Polio. The sheer scale and logistical audacity of the global effort against polio is genuinely mind-blowing when you look at the numbers.
The text notes that in the mid-1990s, the global health community launched National Immunization Days, or NIDs.
To give you a sense of the scale, in just the single year of 2003 alone, roughly 415 million children under 5 years old across 55 different LMICs were immunized.
415 million children in 1 year.
It's staggering. Health workers and volunteers delivered over 2.2 billion doses of the oral polio vaccine.
We are talking about mobilizing armies of volunteers with cold boxes, literally walking to the most remote villages on Earth.
And the epidemiological results of that staggering logistical effort were undeniable.
By the end of June 2009, indigenous wild polio virus had been cornered. It existed in only 4 countries globally: Afghanistan, Pakistan, India, and Nigeria.
And by mid-2012, India, which many experts thought would be the hardest place on Earth to stop the virus due to population density and sanitation challenges, had been officially removed from the endemic list.
Which is an incredible triumph.
It left the indigenous transmission of wild poliovirus isolated to just 3 final, incredibly difficult geographical reservoirs: Afghanistan, Pakistan, and Nigeria.
But this massive, undeniable success brings up a profound systemic tension that every public health trainee needs to understand.
We need to talk about the vertical program.
The polio eradication effort is the absolute textbook example of a vertical program.
Yes, it is highly focused on a single disease. It is heavily funded by external international donors. It has its own dedicated management structures.
And it operates almost like a military campaign driven from the top down.
Exactly. So how does this vertical model conflict with the idea of horizontal system strengthening?
Which is the day-to-day work of building a broad, resilient health system.
This specific tension, vertical versus horizontal, is a debate you will encounter constantly in global health policy, health economics, and on the ground in LMICs.
Vertical programs are incredibly popular with donors.
Because they deliver rapid, easily measurable epidemiological gains. If a donor wants to drop the incidence of polio or distribute millions of bed nets for malaria quickly, a vertical campaign with dedicated, ring-fenced funding, bespoke supply chains, and highly paid dedicated staff absolutely works.
The metrics are clean. You can show your board of directors exactly how many vaccines were delivered.
Right. But the systemic tension lies in the fact that these powerful vertical programs can inadvertently overwhelm, distort, and even hollow out the fragile baseline health systems they are operating within.
It's like building a high-speed rail line right through the middle of a town, but ignoring all the local roads.
That's a great analogy. If all the functioning four-wheel drive Jeeps, all the reliable cold chain refrigerator capacity, and the most competent, highly trained local staff are pulled away by the lucrative salaries of the vertical polio or HIV campaign, what happens to the routine horizontal system?
What happens to the everyday comprehensive primary care network?
The District Maternal and Child Health Clinic, which is quietly trying to manage preeclampsia, basic nutrition, and routine childhood illnesses, can actually be severely weakened.
Because it has been stripped of its resources by the well-funded vertical silo operating right next door.
It creates an internal brain drain within the country's own health system.
So if a vertical eradication campaign is this resource-intensive and potentially disruptive, what does this all mean for the ultimate endgame of polio?
The text actually speculates on a terrifying high-stakes scenario. What happens if this vertical eradication effort simply stalls out or fails?
We already deal with the complex issue of circulating vaccine-derived polioviruses causing outbreaks in under-immunized populations.
And we still have these final endemic reservoirs facing immense geopolitical and security challenges.
If the world gets fatigued, defunds the initiative, and fails to eradicate the wild poliovirus, the text states bluntly that it would be the most expensive public health failure in history.
The virus would rapidly break out of its current reservoirs and return globally.
You can't just pause an eradication effort at 99%. If you don't completely cross the finish line, the whole house eventually burns down.
Which is exactly why the World Health Assembly explicitly declared the completion of polio eradication a programmatic emergency for global public health.
The stakes are existential for the architecture of global health. The surveillance systems, specifically the global network monitoring for cases of acute flaccid paralysis in children and sampling environmental sewage for the virus, must remain incredibly sharp.
And fully funded until the very last transmission chain is broken globally.
Let's pivot slightly from these massive, high-profile vaccine campaigns to an area of global health that historically lived in the shadows.
Neglected tropical diseases.
Neglected tropical diseases, or NTDs, and what I like to call engineering solutions.
NTDs are a diverse group of communicable diseases that prevail in tropical and subtropical conditions.
They cause immense chronic suffering, severe disfigurement, and devastating economic loss for the world's poorest populations.
Yet historically, they received very little attention or research funding from the global north.
Because they don't generally threaten the wealthy countries.
Exactly. But the text provides some incredible, highly instructive success stories in how we are finally battling them. Take leprosy, for example.
For centuries, it was a disease of deep stigma and isolation.
But by successfully introducing and scaling up multi-drug therapy, or MDT, which combines rifampicin, clofazimine, and dapsone, the number of new cases globally was slashed.
from a peak of around 775,000 in 2001 to just 228,500 by 2010.
Another remarkable example of scaling a solution for an NTD is the fight against lymphatic filariasis.
That's a parasitic infection spread by mosquitoes that causes severe, permanent disability and gross enlargement of limbs, known as elephantiasis.
The Global Elimination Program, launched in 2000, took a massive population-level approach. They delivered more than 3.4 billion doses of anti-parasitic medicines to nearly 900 million people across endemic countries.
By combining this annual mass drug administration to clear the microfilariae from human bloodstreams with aggressive vector control to reduce the mosquito population, they have successfully interrupted the transmission cycle in many regions.
But here's where it gets really interesting from a public health engineering standpoint. Let's look at dracunculiasis, more commonly known as guinea worm disease.
The historical numbers here are just staggering. In 1986, there were an estimated 3.5 million cases across 20 countries in Africa and Asia.
And by 2011, the global incidence had plummeted to fewer than 1,100 cases, almost entirely isolated in South Sudan.
And here is the kicker for your clinical reasoning. The global health community achieved this near eradication without a vaccine.
And without any specific curative medicine.
How is it possible to drive a parasitic disease to the brink of extinction without pharmaceutical intervention?
It was achieved through pure, rigorous behavioral and environmental engineering.
It's all about interrupting the life cycle.
Exactly. The intervention relied almost entirely on interrupting the parasite's life cycle at the source. It involved providing safe drinking water by utilizing incredibly simple, low-tech water filtering techniques.
We are talking about teaching communities to literally filter the microscopic copepods, the water fleas that carry the infective guinea worm larvae out of their drinking water.
Using specially designed fine mesh nylon cloths, or even simple pipe filters worn around the neck.
But filtering alone wasn't enough, right?
No, they combined this environmental modification with intense village-by-village surveillance to rapidly identify human cases.
Because when the meter-long adult female worm begins to painfully emerge from a blister on the patient's leg, the instinct is to soothe the burning pain by wading into a local pond or stepwell.
And that releases millions of new larvae into the water supply, starting the cycle all over again.
So the public health triumph was mobilizing community health workers to identify every single patient, treat and bandage their wounds, and strictly prevent them from contaminating the water sources.
It is a profound testament to the power of primary prevention through environmental modification and community engagement.
It is a perfect example of community-led upstream engineering. Another brilliant example of a multi-tiered intervention for an NTD highlighted in the text is the battle against trachoma.
Trachoma is a chronic keratoconjunctivitis caused by repeated infections with the bacterium Chlamydia trachomatis.
It is the world's leading infectious cause of blindness.
And it is strongly, undeniably linked to poor facial hygiene, crowded living conditions, and a lack of clean water.
To combat this, the WHO advocated for a comprehensive approach known as the SAFE strategy, S-A-F-E.
This is a highly testable concept for trainees because it perfectly maps out how to approach a complex disease from multiple angles simultaneously.
I know the S and A are focused on the clinical side, surgery and antibiotics, but the F and E are where the real public health architecture comes in, right?
Exactly. The SAFE strategy is an elegant, comprehensive synthesis of secondary and primary prevention.
Let's break down the acronym.
The S stands for surgery. Specifically, a simple, relatively inexpensive surgical procedure to correct the inward-turning eyelashes, a condition called entropion with trichognesis.
Because when the eyelids scar from repeated infections, the lashes turn inward and constantly scrape the cornea.
Which is what ultimately leads to blinding corneal opacities. The surgery corrects the anatomical defect.
Then the A stands for antibiotics.
Typically a single oral dose of azithromycin or daily applications of tetracycline ointment to clear the active chlamydial infection in the community.
So those two pillars represent secondary prevention, treating the existing disease to halt progression and prevent the ultimate, irreversible complication of blindness.
But as you noted, the strategy doesn't stop at the clinic door.
It can't, or they'll just get reinfected.
Right. The F stands for facial cleaning, promoting hygiene to remove the eye and nasal discharges that attract the eye-seeking flies which spread the bacteria.
And the E stands for environmental improvement,
which means increasing access to water and sanitation to reduce the fly populations and facilitate better hygiene.
These represent primary prevention, changing the fundamental behavioral and environmental conditions so the transmission cycle is broken entirely.
You cannot just perform the eyelid surgery without fixing the environment, or the patient will simply be reinfected. The scarring will return and the blindness will proceed. It requires the complete architectural blueprint.
Upstream engineering combined with downstream clinical care. It is beautiful, holistic public health architecture.
But just as these LMIC health systems begin to get a handle on these infectious scourges, a completely new, devastating storm hits the house.
Welcome to the massive epidemiological shift we call the epidemiologic transition and the double burden of disease.
This transition is perhaps the most defining, complex characteristic of modern global public health.
LMICs are currently experiencing a massive, incredibly rapid epidemiological shift.
Historically, these nations were defined by high mortality from infectious diseases, malnutrition, and maternal and perinatal conditions.
But according to the data in the text, by 2008, 63% of all global deaths, that is an astounding 36 million people, were caused by chronic non-communicable diseases, or NCDs.
We are talking about cardiovascular diseases, diabetes, cancers, and chronic obstructive respiratory diseases.
And the burden of these NCDs is not just a rich world problem anymore. In fact, it is heavily skewed toward the developing world.
The data shows that more than 60% of the global burden of cardiovascular disease and more than 70% of all cancer deaths now occur in LMICs.
We have to clearly establish the double burden framework here for our listeners.
Let's go back to our architectural house.
Imagine the health system in an LMIC is still actively fighting off the termites, the old scourges, the malaria, the tuberculosis, the lingering NTDs.
While simultaneously the roof is caving in from a completely different structural failure, the crushing, expensive, long-term weight of chronic NCDs.
And here is the crucial clinical connection that brings these two seemingly disparate burdens together, a connection that many trainees miss when they silo their studying.
It is common to think of infectious diseases and NCDs as entirely separate categories of pathophysiology.
But in LMICs, many major NCDs, particularly cancers, have direct infectious origins.
Look at the oncology data. Liver cancer, which affects roughly 5.5 million people globally, is predominantly driven by chronic viral infections like hepatitis B and hepatitis C.
Stomach cancer is deeply causally linked to chronic Helicobacter pylori bacterial infection of the gastric mucosa.
Cervical cancer, a leading killer of women in LMICs, is almost entirely caused by chronic persistent infection with high-risk strains of the sexually transmitted human papillomavirus, or HPV.
This is a profound conceptual shift for a clinician. Treating or vaccinating against a specific infection is quite literally cancer prevention.
Scaling up pap smears, visual inspection with acetic acid, and delivering HPV vaccines to adolescent girls are incredibly powerful, cost-effective tools to prevent cervical cancer mortality before it ever develops into an NCD.
Treating H. pylori early with a simple course of antibiotics and proton pump inhibitors actively prevents the long-term cellular changes that lead to stomach cancer.
But zooming out, how does a fragile national health system possibly manage this massive influx of traditional lifestyle NCDs like skyrocketing rates of type 2 diabetes and hypertensive heart disease alongside these persistent infectious threats?
If we connect this dual threat to the broader systemic picture, managing this double burden requires a highly coordinated dual approach.
A developing health system simply cannot treat its way out of an NCD epidemic on an individual curative basis.
The cost of lifelong pharmaceuticals, dialysis, and bypass surgeries would instantly bankrupt the Ministry of Health.
Therefore, the foundation must be built on population-wide primary prevention.
This often means aggressive legislative and fiscal policy measures to mitigate systemic risk factors at the source.
Implementing heavy taxation on tobacco products, restricting the marketing of alcohol and ultra-processed foods, and redesigning urban spaces to encourage physical activity.
But you cannot ignore the sick. You must combine that broad population approach with targeted, cost-effective screening and clinical management for high-risk individuals at the primary care level.
Right, because the individual clinical care for chronic diseases is still severely lacking in these settings.
The text notes a truly heartbreaking reality to illustrate this gap. Many patients with type 1 insulin-dependent diabetes living in LMICs still do not have reliable, affordable access to basic, life-saving insulin.
Contrast that stark reality with the management of the exact same autoimmune disease in a high-income country.
It sharply emphasizes the unfinished architecture of pharmaceutical equity. If you have a chronic disease that requires daily, lifelong medication, and you live in a fragile health system that relies heavily on out-of-pocket payments or sporadic, unpredictable donor funding, the architecture is going to fail you, and the outcome is fatal.
Which brings us directly to the core mechanisms of how these health systems are actually constructed, governed, and funded.
We need to examine system strengthening and the political economy of health.
To understand the current structure, we have to look back at a pivotal moment in global health history, 1978.
1978, the Alma-Ata Declaration. If you are taking a global health exam, this is guaranteed to be on it.
It was a massive philosophical turning point.
Before the International Conference on Primary Healthcare in Alma-Ata, Kazakhstan, many developing countries were heavily reliant on those fragmented, vertical programs we discussed earlier.
For instance, setting up standalone maternal and child health, or MCH, centers that only dealt with specific issues.
But governments quickly realized that deploying specialized MCH workers in isolation wasn't enough to expand comprehensive care to rural populations.
Alma-Ata championed the bold principles of health for all by the year 2000.
And fundamentally advocated for integrated primary health care, or PHC, as the central function and main focus of a country's health system.
The shift to primary health care meant moving decisively away from the highly centralized, heavily curative, urban hospital-based models that were largely inherited from the colonial era.
Instead, it focused on providing comprehensive, accessible, community-based care that included health education, nutrition, safe water, maternal and child health, immunization, and provision of essential drugs.
But as these LMICs attempted to operationalize the Alma-Ata vision, they quickly encountered a harsh economic reality.
They found that the public sector alone, funded by limited domestic taxation, simply could not bear the enormous financial and logistical cost of expanding basic healthcare infrastructure to the entire rural and urban poor population.
They had to innovate structurally.
And one of those key structural innovations was the formal creation and integration of a third layer of the health workforce.
To expand their reach, governments sought partnerships with private practitioners, traditional healers, non-governmental organizations.
And crucially, they deployed massive numbers of community-level health volunteers.
These community health workers, often trained for relatively short periods in basic interventions, became the essential, localized frontline for disease prevention, childhood growth monitoring, epidemic surveillance, and grassroots health promotion.
They became a connective tissue between the formal clinic and the village.
Yet, despite these workforce innovations, the glaring systemic issue remains financing.
How exactly do sovereign countries build and sustain a comprehensive national health system when they have fundamentally insufficient revenue?
Let's look closely at the macroeconomic data provided in the text.
Total health expenditure as a proportion of gross domestic product, or GDP, in LMICs typically ranges from a mere 1.9% to about 6%.
Compare that anemic investment to high-income countries, which routinely spend more than 11% of their vastly larger GDPs on health.
To put it in absolute terms per capita, government expenditure on health in low-income countries is often hovering around $30 per person per year.
In high-income countries, that figure routinely exceeds $2,600.
So the ultimate economic question is, who actually pays for the care? When the national government is only capable of spending $30 a person, the financial burden doesn't disappear.
It is passed directly down to the sick patient at the point of service.
This structural deficit leads to massive, crippling out-of-pocket, or OOP, costs.
High out-of-pocket expenditure is the exact opposite of universal health coverage. It forces families into catastrophic health expenditures,
where a single medical emergency like a complicated delivery or a traumatic injury forces them to sell their land or livestock, plunging them into deep poverty.
Because broad social health insurance pools are very low or virtually non-existent in many Asian and African LMICs, these nations are forced to turn outward to the global community to bridge the gap.
The text points out a massive surge in this dynamic. Development assistance in health, or DAH, more than doubled between 2001 and 2009, skyrocketing to $27.7 billion annually.
This is where we must delve critically into the governance and financing framework of global health. The influx of external aid is undeniably a life-saving intervention for millions, but excessive, uncoordinated reliance on foreign donors creates deep systemic vulnerabilities for a sovereign nation.
In several African LMICs, external resources account for 20 to 60% of their total national health expenditure.
In extreme cases, like Malawi during certain periods, external aid accounted for as much as 80% of the total health budget.
80%. Just pause and imagine trying to govern and run a cohesive national health system where 80% of your operating budget is entirely controlled by foreign governments, philanthropic foundations, and international NGOs.
This economic reality brings us right back to the tension of vertical versus horizontal programming we discussed earlier.
We have massive, immensely powerful global health initiatives. Entities like the Global Fund to Fight AIDS, Tuberculosis, and Malaria, JVI, the Vaccine Alliance, and the Bill and Melinda Gates Foundation.
If these massive donors strictly dictate that their billions of dollars can only be used for their specific disease priorities, what actually happens to the architecture on the ground?
It inevitably distorts the national priorities of the recipient country. It causes severe fragmentation of the health system.
You might easily have a situation where a desperate Ministry of Health watches all its highly trained nurses migrate into a well-funded, donor-backed AIDS clinic because that NGO can offer double the salary, reliable electricity, and consistent medical supplies.
Meanwhile, the government-run maternal health ward next door is left completely understaffed, lacking basic oxytocin to stop postpartum hemorrhages.
Furthermore, the proliferation of dozens of different donors, each with their own unique reporting requirements, auditing cycles, and parallel supply chains, places an immense administrative burden on the Ministry of Health.
It can actually weaken the overall governance capacity of the health system instead of strengthening it, inadvertently allowing national governments to avoid the difficult political work of building long-term, sustainable domestic tax bases for health.
To combat this dangerous fragmentation, the text highlights a major push toward global harmonization and alignment.
Around 2005, recognizing the chaos, the United Nations introduced the delivering as one principle advocating for one UN leader, one budget, one program, and one office at the country level.
And building on that, in 2007, the IHP plus ACA, the International Health Partnership, was launched.
The core goal of these initiatives was to create joint, unified assessment tools to align all external donor programs directly behind the recipient country's actual sovereign national health policies and priorities, rather than allowing donors to run their own parallel, fragmented health systems.
It is fundamentally about country ownership and systemic coherence. An architecture cannot possibly be stable if 50 different international subcontractors are aggressively trying to build 50 different specialized rooms without ever consulting the Ministry of Health's master blueprint.
The aid must support the foundation, not just decorate the facade.
Exactly. And the most vital, indispensable resource in that entire master blueprint is the people, the health workers.
Which brings us to human resources, research, and social determinants. The economics of healthcare are labor-intensive.
Human resources consume roughly 60 to 70% of recurrent public health expenditure.
Yet despite this massive budgetary footprint, LMICs face crippling, absolute shortages of trained medical personnel.
The underlying reasons for this severe workforce crisis are multifaceted and deeply systemic. First, there is chronic, historical underinvestment in basic medical, nursing, and public health education capacity within these countries.
Second, there is widespread mismanagement resulting in poor career structures, inadequate living conditions in rural postings, and a lack of supportive clinical supervision.
And critically, there is the phenomenon of the brain drain, the active, ongoing loss of the existing, highly trained workforce as doctors and nurses emigrate to higher-income countries in the global north, seeking better pay, safer working conditions, and professional advancement.
Furthermore, the text critiques the nature of the training itself. Often, the medical curricula in LMICs are obsolete or heavily biased, modeled almost entirely on a high-tech, Western biomedical clinical approach training doctors for tertiary hospitals, rather than focusing on the actual immediate public health and primary care needs of the rural population.
But the health workforce, even if fully staffed, is only part of the equation, because human health doesn't just happen inside the four walls of a clinic.
In 2008, the WHO released a pivotal paradigm-shifting report from the Commission on Social Determinants of Health.
This report hammered home the undeniable epidemiological reality that health inequities, the unfair and avoidable differences in health status between groups, are driven fundamentally by the conditions in which people are born, grow, live, work, and age.
Factors like social exclusion, housing quality, early childhood development, and the occupational environment dictate an individual's health risks long before a doctor or nurse ever has the chance to intervene.
This framework of social determinants brings us to a perfect, stark illustration of how rapid economic development and social conditions collide to create new epidemics.
Let's look at the rising epidemic of injuries, specifically road traffic fatalities. The text provides a staggering, highly disproportionate statistic. LMICs possess only about 48% of the world's registered vehicles, yet they account for over 90% of the world's global road traffic fatalities.
Let's focus on pattern recognition here for our listeners. Why is that massive discrepancy happen? Why is driving in an LMIC so disproportionately lethal?
It perfectly illustrates a highly dangerous gap in a nation's development timeline. It occurs when rapid economic transition aggressively outpaces structural and legislative transition.
Think about the mechanics. A country experiences rapid economic growth, lifting millions into the middle class. Suddenly, millions of people can afford to purchase motorized two-wheelers or cheap cars. There are a million new vehicles hitting the roads every single day.
That is the economic transition.
But the structural and regulatory transition, the expensive, time-consuming building of safe, separated road networks, the strict enforcement of helmet and seatbelt laws, the implementation of drunk driving legislation, and critically, the establishment of rapid pre-hospital EMS and specialized trauma response systems lags years, if not decades, behind the influx of vehicles.
The result is massive, entirely preventable mortality. The hazard high-speed motorized transport is introduced to the population long before the protective public health architecture is built to mitigate the risk.
It is the unfinished architecture literally claiming lives on the asphalt daily.
We see a very similar legislative and regulatory lag when it comes to the globalization of the tobacco epidemic. The WHO Framework Convention on Tobacco Control, or FCTC, was a landmark treaty adopted in 2003 to combat the estimated 4 million annual deaths globally from tobacco use.
But in specific geographic regions, the public health threat is culturally unique and deeply entrenched. For instance, in South and Southeast Asia, there is a massive localized issue with the widespread consumption of betel quid, or areca nut, often combined synergistically with smokeless tobacco.
This highly carcinogenic combination causes severe epidemic rates of oral, laryngeal, and gastrointestinal cancers. Broad, generic, global legislation is insufficient. Public health measures must adapt to these highly localized cultural determinants of health.
And this pressing need for systemic adaptation brings us to our final major theme: globalization, aging, and the future of public health architecture. The world is vastly more interconnected than at any point in human history.
We saw the United Nations establish the Millennium Development Goals, or MDGs, which set specific time-bound targets for 2015 to tackle extreme poverty, child mortality, and maternal health, serving as a powerful unifying framework for global development.
More critically, for global health security, we saw the implementation of the updated International Health Regulations, or IHR, in 2005, which entered into force in 2007.
Let's make sure our listeners understand what the IHR actually does. It is not just a suggestion, it is a legally binding international treaty. The older versions of the IHR were highly restrictive, focusing almost exclusively on border control and quarantine for just 3 diseases: cholera, plague, and yellow fever.
But the updated IHR fundamentally shifted the paradigm. It requires all 196 member states to develop the core public health capacities to detect, assess, report, and respond to any public health emergency of international concern, or PHEIC, regardless of the pathogen.
It shifted the focus from static border control to dynamic systemic readiness and global transparency, attempting to coordinate responses to the international spread of disease without unnecessarily interfering with global traffic and trade.
And that systemic readiness is non-negotiable because the biological threats move faster than ever. We aren't just dealing with the predictable scourges anymore. We are constantly facing emerging and re-emerging threats of immense epidemic potential.
HIV/AIDS, Ebola virus disease, SARS, and highly pathogenic avian influenza.
A novel virus can now board a commercial flight in a rural LMIC and land in the center of a high-income metropolis in under 12 hours. The intense global flows of trade, finance, information, and people mean that national borders are biologically meaningless.
Global health security is no longer a matter of charity. It is truly a shared collective responsibility.
And simultaneously, while we are watching the skies for the next pandemic, a quiet, profound demographic transition is fundamentally reshaping these nations from within.
Because of the very public health successes we have discussed today, the scale-up of vaccines, the control of infectious diseases, the drop in infant mortality, people in LMICs are living significantly longer.
There is an unprecedented, rapidly expanding population of people over the age of 60.
Yet, because the health systems were historically built to fight childhood infections and maternal mortality, many of these countries entirely lack the social welfare systems, pension schemes, and targeted geriatric healthcare infrastructure required to support healthy aging.
The basic primary health workers, trained to weigh infants and deliver vaccines, often have minimal training regarding the specific, complex geriatric and chronic care needs of this fast-growing demographic. The blueprint has to change again.
So we have comprehensively covered the colonial history, the evolution of disease control, the complexities of health financing, and the shifting demographics.
Before we move to our learning reinforcement, it is vital to tie all these threads together with a profound shift in perspective derived from the conclusion of the chapter. Often, in economic and political circles, policymakers view population health merely as the result or the dividend of a country getting richer.
But the text flips this common assumption entirely on its head.
It does, and this is a crucial piece of reasoning for you to take away into your careers. Health is fundamentally a cause rather than just an effect of economic development.
Investing in public health literally determines a nation's economic productivity and future prosperity. Let's look closely at the mechanism of this through the concept of the quality-quantity trade-off in child-rearing.
When a nation's infant and child mortality rates are exceedingly high due to infectious diseases, families lack the secure knowledge that their children will survive into adulthood.
Consequently, as a rational economic strategy, they maintain very high fertility rates, having many children, to ensure at least some survive to provide agricultural labor and support them in old age.
But when you introduce robust public health interventions, like the EPI vaccines, clean water, and maternal care, and infant mortality precipitously drops, families experience a profound demographic shift.
Recognizing that their children will survive, they begin to invest significantly more concentrated resources, education, and time into fewer children. This is the quality-quantity trade-off.
This shift lowers national fertility rates, dramatically increases the education and skill level of the emerging workforce, reduces the dependency ratio, and directly builds massive economic prosperity.
Breakthroughs in public health are not a luxury item. They are the literal engine of macroeconomic development. You don't wait for your country to get rich so you can finally afford to get healthy. You must invest in getting the population healthy in order to get rich.
That is precisely why finishing this architecture of equity is so vital to the future of the globe.
All right, it is time to solidify these expansive frameworks. We are moving into our learning reinforcement section. Before we wrap, let's lock in a few high-yield takeaways you are almost guaranteed to see on your global health modules or board exams.
For those of you listening, I'm going to ask 5 rapid single best answer style recall prompts based on the deep dive today.
I will read the question, I will give you a brief pause to think and commit to an answer in your head, and then our expert will deliver the correct answer and tell you exactly which section of the Oxford chapter you need to revisit if you missed it. Ready? Let's build the scaffolding.
Prompt 1. What specific economic metric does the United Nations utilize to classify countries into low and middle income brackets?
Think about that for a second.
The answer is per capita gross national income, or GNI. You can review the exact economic brackets in the introduction section of the chapter.
Prompt 2. Which specific neglected tropical disease was reduced from 3.5 million cases to roughly 1,100 cases globally by 2011, relying almost entirely on behavioral and environmental engineering interventions like water filtering and surveillance, rather than the use of vaccines or curative medications?
Take a moment.
The answer is Broconchioliosis, also commonly known as guinea worm disease. This remarkable eradication effort is detailed in the neglected tropical diseases section.
Prompt 3. In the WHO's SAFE strategy used comprehensively for trachoma elimination, what does the E stand for?
Think about the whole acronym.
The E stands for environmental improvement. The full multi-tiered strategy is surgery, antibiotics, facial cleaning, and environmental improvement. You can review the mechanics of this in the neglected tropical diseases section.
Prompt 4. Following the massive success of global national immunization days, which 3 specific countries remained the final isolated reservoirs for endemic transmission of indigenous wild poliovirus by mid-2012?
Have an answer ready.
The answer is Afghanistan, Pakistan, and Nigeria. The complexities of this endgame can be found in the section covering the elimination of vaccine-preventable diseases.
Prompt 5. Illustrating the dangerous gap between economic and structural transition, What massive percentage of global road traffic fatalities occur in LMICs, despite these nations possessing only 48% of the world's registered vehicles?
Think about the magnitude.
The answer is over 90%. This stark, disproportionate statistic regarding the social determinants of injury is located in the preventing injuries section.
Excellent work. If you nailed those, your clinical and public health reasoning is in great shape. If you missed a few, you know exactly where to go back and focus your active reading.
As we wrap up this conceptual companion, we want to leave you with a final provocative thought, something to mull over as you walk onto the ward for your next shift, or sit down to write your next public health policy paper.
We've talked extensively today about how these historical colonial fortresses were hastily expanded and remodeled into national health systems.
But as climate change aggressively begins to redraw the map of infectious diseases, altering rainfall patterns and pushing vectors like malaria-carrying mosquitoes into entirely new, higher altitudes and latitudes that were previously untouched, we have to ask a difficult question.
Are the architectural blueprints and rigid vertical programs we are relying on today adaptable enough to survive the chaotic global health climate of tomorrow?
Or are we still just frantically patching the roof while the very ground shifts beneath the foundation?
A brilliant and necessary question to ponder as you step into your careers. Keep reading, keep questioning the frameworks, and always keep connecting the dots between the vast sweep of history and the individual patient sitting right in front of you.
Here are the details of this episode. GPH 3, the history and development of public health in low- and middle-income countries.
Byline: Health in the Shadow of Empire, Decolonization, Development, and the Unfinished Architecture of Equity.
Episode description. Public health in low- and middle-income countries, or LMICs, followed a markedly different trajectory from that of industrialized nations. While European public health evolved alongside domestic urban reform, much of public health infrastructure in LMICs emerged within colonial systems, often designed to protect colonial interests rather than indigenous populations.
In this episode, we explore how colonial medicine prioritized port cities, military personnel, and economic productivity. Disease control efforts frequently targeted threats to trade and governance rather than broader population health.
With decolonization in the mid-20th century came an ambitious reimagining of health systems. Newly independent nations confronted infectious disease burdens, fragile infrastructures, workforce shortages, and limited fiscal capacity. The Alma-Ata Declaration of 1978 marked a pivotal moment, advocating primary health care as the foundation for equitable development.
We examine tensions between vertical disease programs, which are focused, externally funded initiatives such as malaria or HIV control, and horizontal system strengthening approaches. Structural adjustment policies, global financing institutions, and donor agendas shaped health system trajectories in complex ways.
This chapter reminds us that global public health cannot be understood without confronting history, particularly the legacies of inequality, dependency, and economic constraint.
Public health development in LMICs is not a lesser version of the Western story. It is a distinct narrative shaped by geopolitics, economics, and global power.
Key takeaways. Colonial health systems often prioritized economic and political interests over equity.
Decolonization created opportunities and structural challenges for national health development.
Primary healthcare emerged as a transformative global vision in Alma-Ata.
Vertical disease programs can produce rapid gains, but risk fragmenting systems.
Health system strengthening requires workforce, financing, governance, and infrastructure investment.
Global institutions and donor priorities significantly influence national health strategies.
Historical inequities continue to shape present-day health disparities.
Understanding LMIC public health requires analyzing political economy, not only epidemiology.